Benign prostatic hyperplasia, or BPH. With BPH, the prostate gland is enlarged. The enlarged prostate can partially or completely obstruct the urethra. If the urethra is obstructed, urine output will decrease because urinary flow cannot exit the body as well. So what can we use to restore urinary flow? A catheter. BPH is caused by hormonal changes. As men age, testosterone levels decrease and the concentration of estrogen increases. High estrogen concentrations produce DHT. DHT promotes prostate cell growth, so that's how you end up with BPH. BPH symptoms are categorized as irritative or obstructive. Irritative symptoms will all be related to inflammation or infection. Obstructive symptoms will all be related to the prostate being enlarged. BPH patients may experience urinary retention because of the prostate squeezing the urethra. They also may have a UTI, pyelonephritis, or even sepsis from urinary retention and bacteria growth. Struvite bladder stones may happen from the residual alkaline urine in the bladder. And lastly, hydronephrosis from urine backflow from the urinary retention. To diagnose BPH, you can do a history and physical, a urinalysis, and a urine culture to look for infection, a prostate-specific antigen test, which is blood work. If that comes back positive or elevated, further testing will be needed. They can do a digital rectal exam to check the prostate for size, symmetry, and consistency. That will be positive if the prostate is smooth, firm, and symmetrically enlarged. Symmetrically enlarged is very important here. They can also do an ultrasound to determine if the patient has BPH versus prostate cancer. A ultrasound is done if the PSA and the digital rectal exam are abnormal, and it also may be done with a biopsy for further testing. Post-void residuals can be done to check for urinary retention and the severity of the obstruction. How should the nurse perform a post-void residual? You will bladder scan the patient immediately after they urinate. BPH management. If symptoms are mild, you can do active surveillance, which is waiting and watching. If symptoms are more problematic, we can do a non-invasive procedure or an invasive procedure. Goals of BPH management without a procedure is to restore urine flow, relieve symptoms, and prevent and/or treat complications. Also note that prevent UTIs by increasing fluids to 2 to 3 liters per day, and encouraging frequent urination should be taught to your patient. BPH diet changes. Teach your patients to avoid bladder irritants because they already have urinary frequency. Also, before bed, they need to restrict fluid intake because they already have nocturia and urinary frequency. BPH med considerations. Teach your patient to avoid decongestants because a side effect of decongestants is smooth muscle contraction. And BPH patients already have a compressed urethra, so this can make it worse. Also teach them to avoid anticholinergics because a side effect of anticholinergics is urinary retention, and BPH patients already experience urinary retention. BPH drug therapy. This can be treated with 5-alpha reductase inhibitors or alpha adrenergic blockers. Sometimes these are used separately and sometimes they are used in combination. That will be up to the physician. What we see a lot of the times is that we start the patient on an alpha adrenergic blocker because they are effective much quicker. So we start them on an alpha adrenergic blocker so we can start treating their symptoms while we wait for the 5-alpha reductase inhibitors to take effect and start treating the problem. So talking about our 5-alpha reductase inhibitors, those suppress DHT production to decrease the size of the prostate. They have a delayed onset though. It takes 6 months for these medications to be effective. That is a really long time. They do have a common ending of RIDE. For your alpha adrenergic blockers, those medications relax the smooth muscles to improve symptoms. So they have a much quicker onset. They're effective in 2 to 3 weeks, so we can start seeing symptom relief earlier, which patients do like. And we have a common ending with these meds as well. These all end in OSIN. On this slide, we have 3 ways to treat BPH with a minimally invasive option. First up is transurethral microwave therapy. Second is transurethral needle ablation. And third is a laser prostatectomy. So when you look at these all together, I want you to look at what these all have in common. They are all destroying the prostate tissue. They're just destroying the prostate tissue in different ways. So you don't have to know which one of these the patient needs. The healthcare provider will determine that, but you will take care of these patients. So let's look at what they all have in common in the post-op phase, which is in the post-op phase, they will all have a urinary catheter. So you will have to maintain that catheter, do catheter care, and teach your patient about good catheter hygiene. This slide talks about the invasive treatment options for BPH. First up is the transurethral incision of the prostate, and secondly, we have the transurethral resection of the prostate. So for the incision, they're going to have an incision that's made into the prostate, and that's going to relieve the pressure on the urethra, which is going to help a ton with symptoms. For the resection of the prostate, they are surgically removing prostate tissue. So in the first one, you have an incision to relieve the pressure, and in the second one, you are actually removing the prostate tissue to treat the problem. Post-op care for patients having a TURP. This was the resection of the prostate, the surgical removal of the tissue. These patients in the post-op phase will have a large 3-way indwelling catheter for irrigation to prevent clots. Hematuria is expected for the first 24 to 36 hours post-op. So worry about bleeding after those first 24 to 36 hours. Post-op urinary drainage is expected to be light pink, and this is because blood mixes with the urine. Anticoagulants should be discontinued prior to the procedure because of the increased risk for bleeding. When should the nurse worry about bleeding in the urinary drainage bag post-op for a TURP procedure? First, we want to worry after 24 to 36 hours. Second is if the bleeding is increased. And third is if the blood is bright red. So we talked a little bit about bladder irrigation with the post-op care of a TURP, but we never really talked about what that is. So the purpose of bladder irrigation is to keep the catheter patent. Bladder irrigation can be done manually with a syringe, or it can be run through a pump automatically. The bladder is irrigated with normal saline when we do this. How do we calculate urine output with bladder irrigation? You need to be sure to only document the urine as output. You do not want to count the normal saline that you instilled as output. So to calculate this, you need to subtract the normal saline that you instilled from the total output in the catheter drainage bag. So looking at this example problem, what is the total urine output for the day with the following values? You emptied 3,500 milliliters from the catheter bag total, and you know that you instilled 2,000 milliliters of normal saline for bladder irrigation. In this case, your total output would be 1,500 milliliters. Okay, catheter care in the post-op phase for these prostate patients. Frequent perineal hygiene and catheter care post-op. Bladder irrigation as needed. Educate the patient to expect temporary weak urinary sphincter tone after removal of the catheter, and that is associated with incontinence or dribbling. So some incontinence and dribbling after removal of the catheter is expected. Urinary sphincter tone can be strengthened with Kegel exercises. So teaching Kegel exercises would be a good intervention. And the catheter will be reinserted if the patient cannot void for 6 to 8 hours after removal. And this is to prevent urinary retention. Before your BPH patient has any of these invasive procedures, we want to give them IV antibiotics to treat any infections before the procedure. If needed, we want to restore the urinary drainage, and that might be done with an indwelling catheter. You also want to do some pre-op education for these invasive procedures. So you want to teach about the post-op care, and that includes 1, bladder irrigation, 2, catheter care, and 3, wound care. Teach about potential complications as well. They may have incontinence for up to 2 months and erectile dysfunctions for up to 1 year. What do you want to monitor for in the post-op phase for invasive BPH procedures? 1, hemorrhage. 2, bladder spasms. 3, incontinence. 4, perineal incision for infection. And 5, constipation. If your patient is experiencing bladder spasms, we can give them oxybutynin, which is an anticholinergic that relaxes the smooth muscles, and that's how it treats those post-op bladder spasms. The side effects of this medication include blurry vision, urinary retention, dry mouth, constipation, and heart palpitations. There is a greater infection risk with some of these invasive BPH treatment options. So the risk is increased when incisions are made in the perineal area, and that is because of the close proximity to the rectum. Diet changes after your patient has an invasive BPH procedure. Teach them to avoid bladder irritants and to increase fluids. This will help to decrease constipation and encourage voiding. Also, teach your patient to prevent constipation by eating a diet high in fiber, taking prescribed stool softeners, and increase their fluid intake to 2 to 3 liters per day. They should also practice abstinence and avoid increasing pressure, including sitting or standing for prolonged times, lifting anything heavier than 10 pounds, and straining with bowel movements. To treat post-op constipation, you can give your patient a stool softener. We want to give these stool softeners with fluids, and a side effect is abdominal cramping and diarrhea. Lastly, here are your BPH risk factors, and as far as which ones are modifiable, that's going to be what the patient can change. So obesity, smoking, alcohol use, lack of physical activity, and diet high in animal protein.